We'll just wait a few moments till all of the participants are able to join. Good afternoon, everyone. Welcome to Quality Rounds Ontario. Today, we'll focus on digital health initiatives, enhancing patient navigation, and optimizing the virtual care experience. I'm Dr. David Kaplan, a family doctor in North Toronto and Vice President Quality at Ontario Health. We are here ready and prepared to acknowledge the sovereignty of the land for the sake of unification. The land I'm speaking to you today from is the traditional territory and sacred land of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Huron-Wendat peoples. We acknowledge these peoples because they have the longest and wisest relationships with this land, a relationship with the land that extends back thousands of years. To recognize the land is an expression of gratitude and appreciation to those whose territory I historically reside on, and a way of honoring the people who have been living and working on the land from time immemorial. My family came to Canada originally from Russia and Poland. They came to escape pogroms and war, starting from the late 1800s till the 1970s. My father was born in a displaced persons camp in Italy after his mom survived Auschwitz and his father survived 5 years in forced labor camps across occupied Poland and Germany. As a Canadian Jew, I know what it means to lose one's Indigenous land and then to be displaced from one's dwelling place, to be persecuted, to be a religious minority in culture. In forming the words of this land acknowledgement, it's allowed me time to reflect on the fact that the wounds of oppression and displacement do not end with the person who suffered the initial trauma. There are second and third generation reverberations and trauma on individual and collective levels. I recognize that many of you attending today virtually are working on parcels of land that do not apply to this land acknowledgement. And I invite you to take some time after the meeting to learn about the colonial and treaty territory of the land you live and work on, and think about how it's connected to the important work you do in the health system. Though my family has also suffered from land displacement and cultural displacement, I want to acknowledge the ways in which I, and many of us on today's call as non-Indigenous people in this land, have benefited from European colonization, which has both hurt and oppressed First Nation peoples. We ask for their forgiveness. May we live in respect on this land and in peace and friendship with its peoples. The objectives for today's session are first, to gain insight into the core and digitally enabled features of Health 811, and to learn how robust clinical oversight has been incorporated into the service. The second is to become more familiar with the clinically appropriate use of virtual care work and how it supports clinicians and patients to optimize their respective virtual care experiences. And last, to better understand the user journey and the impact of these initiatives on patient navigation and healthcare delivery. Today's sessions are accredited with the Royal College of Physicians and Surgeons and the College of Family Physicians of Canada. Members and MainPro Plus participants can claim certified credits for this activity. You can enter questions into the Q&A box or tweet questions using the hashtag #QualityRounds. Technical assistance can be reached by emailing us at quality and patient safety at ontariohealth.ca. We'll put that link to the email address in the chat, and certificates of attendance will be issued via this email address in coming days. So I'm first going to review and provide really a brief overview of the phase 1 of our primary care virtual care guidance. I had the opportunity to co-chair this work with Dr. Onil Bhattacharya, and I'm going to share this work with you today before we hear more about the work in some specific specialties. Next slide. So in March 2020, as many of us will remember, clinical service in Ontario and really across the world rapidly transitioned from in-person to virtual, primarily based on the data by telephone. At the end of July 2022, about 35% of all primary care visits billed to OHIP were delivered virtually. This is now less than 15%. Virtual care was initially used to minimize in-person interaction, to minimize risk to the novel SARS-CoV-2 virus. Ontario Health, however, began work in 21-22 that initially focused on primary care because we felt it had the potential for the greatest impact. But Ontario Health does acknowledge that similar work is needed for other specialties, and we're going to share some of that specialty-related work with you today. And so what we did do through the establishment of an expert panel that included physicians and NPs and patient partners, we developed clinically appropriate use guidelines for virtual care. These are not best practice, but this is really guidance to the profession and to patients and to people about how to best integrate virtual care into the way they interact with primary care moving forward. Next slide. The phase 1 guidance included, I should say, a number of different products. The first was a reference document, and this really provided the background, the details, why we created this guidance and the guidance itself. The second document is more concise, and it really speaks to the target audience. It's focused around the concepts and quality statements and provides the essential information to clinicians and to the system. We also created some supporting tools that were meant to be patient-facing. Both of them are available in a static version, but also in a customizable Word version that individual practices or clinicians can edit. The first is really about learning about virtual care options, and it provides an overview of each of the different modalities that practices can really customize depending on which modalities they offer their patients. And the second is a checklist for the use of virtual care. And this was meant for patients to be able to self-assess whether and which options may best be able to suit them, and then to be able to flag clinicians and their practices for their role in decision-making. You can imagine a patient that doesn't have access to broadband internet or to a safe and private space. It's very difficult for them to use video as a form of virtual care, for instance. Next slide. The document on the left is that guidance reference document that you can download from our website. We'll show you in a minute how to do that. And this is on clinically appropriate use of virtual care. And then the shorter document is available as well. Next slide. The reason we provided or created this small concise statement is because of the feedback we got from the field and from clinicians. And really there are 3 types of statements in the document. One of them is around planning for primary care virtual visits. The second is really assessing, documenting, and communicating a patient's ability to receive virtual care services, and how does one go about documenting that so the front staff who are booking appointments know what patient preferences are and what they're able to do. And the last is really around the virtual delivery of primary care, using the best available current evidence, thinking about determining the use of which modality in a patient-initiated way, but then again, also in a clinician-initiated way. And lastly, how do you document those virtual care encounters, which are really, at the end of the day, just care. Next slide. So the summary for clinicians, as I mentioned, we wanted to create a one-pager, which we did. Again, you can download that from our website. This is a real quick just reference of and distillation of the larger document. And this was around hearing that clinicians really have limited time and they want the quick takeaways from the work that we've done. And on the next slide, what you'll see is the patient-facing tools. And as I mentioned, the patient-facing tools are available in two different formats. One of them is a standalone tool. It's branded with Ontario Health branding. It's available on our website. And the second is really the same document in a customizable way. You can add your practice logo or hospital logo or community health center logo, figure out which virtual care options you're making available, and then be able to share it with patients and clients in your practices. Next slide. So these are the two documents that I mentioned. One of them is learning about virtual care options. You can see explaining the difference between telephone, video, secure messaging. I should note for many of the clinicians on the call that provide virtual care, many of you know that in Ontario, both telephone and video appointments are what is reimbursable under OHIP. We did include all the different types of modality around virtual care because we thought if we're already creating a document for clinicians and for patients, we should include all the different types of modality. There was definitely a pilot in Ontario pre-pandemic around virtual care, which showed that asynchronous messaging really was a preferred modality for patients in the delivery of virtual care to them. Next slide. And then the second patient-facing tool is this checklist for virtual care. And this is to ensure that patients and their family members have the right setup, either at home or wherever they're taking that clinical visit from. Making sure that they've set aside dedicated time to have the appointment. We've heard from a variety of different professions, not just from medicine, but people who are lawyers and judges, about people taking appointments, from the drive-through at Tim Hortons. But it's really important for people to think about this just like they would any other visit and make sure they dedicate the right space, private space, space to think about, to be able to document the conversation they're having with their care provider. And so we created this checklist, not just from a technical standpoint, but also from just a procedural standpoint around receiving virtual care. And we've made these available, as I mentioned, either in a static form where you can just send the PDF or customize it yourself. Next slide. So as I mentioned, all these products are available on our Ontario Health website. If you navigate to ontariohealth.ca and you don't remember the full URL, which is /virtual care guidance, if you go to providing healthcare, that second tab on the top, and then you go to clinical standards and guidelines, you can see right on the right side there, clinically appropriate use of virtual care, and all the things we're talking about today are available there when it pertains to virtual care guidance. Next slide. So I've given you an overview today of some of the work that we've done around, in general, around virtual care, specifically in primary care, family medicine, nurse practitioners. But we do want to be able to focus as well on some of the new guidance that we've released since then, which really focuses on specialties. And so it's really my pleasure to introduce two team members on this work. The first is Dr. Michelle Laliberté. Dr. Laliberté currently directs a CBT-based program for adults with eating disorders at St. Joseph's Healthcare in Hamilton. She's an assistant professor in the Department of Psychiatry and Behavioral Neuroscience at McMaster University and a faculty member at the Peter Boris Center for Addictions Research. She's published research papers and presented at many international conferences on eating disorders. Dr. Laliberté has also trained numerous healthcare professionals, both in individual and group CBT treatment for eating disorders. She's also developed treatment manuals for binge eating disorder, and body image that are used in programs across the province. She's currently researching factors associated with recovery and the treatment of disordered eating. In addition to her administrative teaching and research activities, Dr. La Liberté also maintains a private practice in eating disorders. Joining her is Tamara Du Amaral. Tamara joined Ontario Health in August 2022 as the lead for clinical guidance and virtual appropriateness. Tamara began her career as a clinical research assistant, looking at how innovative technologies could support children living with chronic conditions. Keen to better understand the clinical world, she completed a degree in nursing at the University of Toronto. Her experiences range from supporting medtech entrepreneurs to working as a frontline clinician. Most recently, she's supporting the development of guidance for the clinically appropriate use of virtual care in mental health and addictions. She's passionate about supporting healthcare transformation initiatives that help improve the experience of patients, clients, and clinicians. Tamara recently joined the prevention and screening team at Ontario Health in the role of lead program delivery. Over to both of you. They're going to be sharing how clinically appropriate use of virtual care is helping clinicians deliver virtual care and decision-making around the selection of virtual care modalities in eating disorders.
Thank you so much, David, for that great introduction. So let's jump right in. Next slide, please. So to give a bit of overview and building off of what David shared, Ontario Health's Population Health and Value-Based Health Systems portfolio receives virtual care-related funding annually from the Digital and Analytics Strategy Division of the Ministry of Health. As previously highlighted, this initiative was funded to continue work begun in response to the high use of primarily telephone-based care delivered during the early COVID-19 pandemic period, to help support clinicians in their decision-making around which modality and in-person care may be better suited in any given clinical context. Next slide, please. So after developing guidance for primary care as that foundational guidance, Ontario Health carefully considered in which other areas guidance could be developed. And the selection criteria included area of focus within Ontario Health's mandate, being aligned with the OH annual business plan and priorities, alignment with priority populations selected by the Ontario Health teams, demonstrated use of multiple modalities, and evidence of variation in practice. The identification of mental health as a target specialty area for guidance development was agreed upon in June 2022. Next slide, please. So to share a bit more about our approach for developing guidance, it includes a review of existing guidance and policies, as well as current state data, in addition to conducting a rapid review of the literature. We then onboard and work collaboratively with an expert panel in a co-design process to confirm the scope and focus and draft the guidance statements, as well as involving the group in co-design of implementation. We then engage the broader community for awareness, have targeted engagements at different stages of development, introduce and seek support, and identify partners for communication, implementation, and evaluation of the guidance. Next slide. So in terms of relevant data, just sharing here on the screen, so this here is for the specialty of psychiatry, and it shows that sudden change from in-person to virtual at the bottom there. You'll note the blue-purple line in the bottom chart. And so at the outset of the pandemic and the gradual decline of virtual and increase of in-person visits over the winter, we only have phone versus video data as of December 2022, when the Physician Services Agreement came into effect, changing the billing rates for each of these. The box on the top right shows video visits were higher than telephone visits and increasing, and noting that video visits are billed at a higher rate than telephone. Next slide, please. So why develop virtual care guidance? So there was limited data to help us understand the current use of virtual modalities in practice and their outcomes. We know that practice guidelines require strong evidence. There were few existing guidelines that would meet the requirements set out for this work, and the evidence in the literature for virtual care, while stronger in mental health than for other specialties, is still emerging. Therefore, the conclusion was that an expert panel would be required to provide the necessary expertise and opinion to form guidance. Next slide, please. So in terms of selecting and working with the expert panel, the Mental Health and Addiction Center of Excellence in October 2022 established a provincial advisory tables and appointed clinical leads for 5 clinical areas. We leveraged the provincial advisory table members for the expert panel as they had recently been appointed to the advisory tables, and we included other clinicians in the regions with varied experience, such as pediatric experience, as well as people with lived experience. The expert panel for the eating disorders guidance met from January to March 2023, and the work had not yet been completed, and so the timeline of the expert panel was extended to end in June 2023. Next slide. So following the review of existing guidelines, current evidence, and data, we discussed decision-making around virtual care delivery with the expert panel. Gaps were identified, for example, a lack of recommendations focused around clinical appropriateness. Guidance statements were drafted, shared, and discussed in the expert panel meetings. The guidance statements were further refined via post-meeting surveys, and statements that did not meet the minimum consensus requirement were discussed further until consensus was reached. Next slide, please. And so I will pass it over to Michelle Laliberté, who is the wonderful chair for this expert panel, to discuss more about the content of the guidance. Over to you, Michelle.
Thanks, Tamara. Okay, so I wanted to start just by talking about the assumptions that I think we all had, and then rethinking of the modalities of care that sort of happened over this process. So as you know, both David and Tamara have noted that at the beginning of the pandemic, the switch from in-person to virtual care was necessary for care to continue at all. And the assumption, I think, at that time for most of us was that in-person was the ideal or the gold standard, and alternatives could be acceptable if necessary. And so in creating the guidance document for the clinically appropriate use of virtual care, we sort of started with the same basis, sort of making the same assumptions. And what we knew is that our experiences, however, over the course of the pandemic had challenged these assumptions. So for example, virtual care was seen as more accessible, attendance was often better, efficacy was looking like it was the same as in-person care. And for eating disorders, there was the discussion of the fact that, people making changes in their home environment might generalize those changes more to their lives than making it in an in-person hospital context. So we wanted a guidance document for eating disorders that presented a balanced approach, one that talked about the strengths and limitations of each modality and what factors to consider in making a choice focused on clinical appropriateness. Next slide. So this is the cover of the Eating Disorders Guidance reference document. And as you can see, there's a table of contents which talks about the key concepts and definitions, the general considerations, and then goes into the actual guidance recommendations. Next slide. So we thought we would just give you a little sampling of some of the basically the guidance statements that were part of this document. So looking at key concepts and definition, and just giving you an example of the clinically appropriate use of virtual care. So the clinically appropriate virtual eating disorder care is safe, timely, inclusive, equitable, confidential, evidence-based, and person or family-centered. It is provided within the scope of practice of the healthcare professional in a setting or using modalities that permit appropriate clinical assessment of the presenting condition and or evidence-based treatment of the presenting condition. So there's the idea of not moving away from our standards of practice. And another example under key concepts and definitions is hybrid models of care. So the use of both virtual care and in-person care, known as a hybrid model of care, has been described in the literature, particularly in the work with eating disorders. So the use of hybrid models of care may be particularly relevant to the context of providing care for people with eating disorders, given the need to address both medical and mental health care. So depending on the clinical context and the preferences of people with eating disorders, some aspects of care may require in-person visits, while others may be facilitated virtually. For example, while certain aspects of a comprehensive mental and physical assessment may require an in-person visit, for example, to have laboratory tests, others may be completely virtual or may be completed virtually. So a family history is an example. Next slide. Oops, wrong direction. Okay, so then looking at the potential risks for people receiving care in a virtual context, one of the risks was their medical status. So as it says here, virtual care for eating disorders can vary based on the unique circumstances of each person due to the differences in and complexities of eating disorders, including the potential for changes in medical status, the need for close physical monitoring, and the presence of comorbid conditions, as well as individual preferences. Where there are concerns about medical instability, depending on the clinical context, a hybrid model of care may be considered. For example, virtual psychotherapy and in-person medical monitoring, whereas in other cases, it may be most appropriate to conduct all aspects of care in person. And then as an example of from the evidence-based psychotherapy in the context of virtual care, looking at considerations for the virtual delivery of cognitive behavioral therapy for eating disorders, which is one of the therapies that was part of the quality standards. Virtual care can allow for the healthcare professional and the person with an eating disorder to collaboratively view self-monitoring records, which are critical to CBT, via screen sharing or secure messaging. However, if technical difficulties prevent this collaborative review, in-person care is encouraged. So again, recognizing people may need to switch if they can't provide evidence-based practice. Next slide. And then finally, just looking at the guidance recommendations. So really what we're looking at here is the healthcare professionals' knowledge and ability. We're also looking at considerations for the preferences, needs, and values of people with eating disorders and for their families and caregivers, considerations for when in-person care may be most appropriate, and informing the method of care delivery. Next slide. So in terms of delivering virtual care for eating disorders, one of the things that was looked at was ongoing assessment and management of potential risks. So ensuring that the healthcare professional is familiar with emergency or crisis resources, and that the person is informed of the types of situations in which emergency authorities may need to be contacted. The ongoing assessment of the virtual care offering itself. So having the healthcare professional discuss the virtual care modality with the person with an eating disorder over the course of the therapeutic relationship or care plan and address any changes in preference as appropriate, knowing that preferences may change over time. And then finally, documenting virtual care encounters. And again, similar to documenting any other encounter, except in this case, also noting that it may include reference to the technology used, the location of the person with an eating disorder during the sessions, and discussions of privacy and confidentiality. Next slide. And then there'll be two slides here where we're looking at the benefits of virtual and in-person care modalities, sorry. And we'll be also looking at the risks associated with the two. And this was our attempt to present a more balanced picture of all the types of care, including in-person. So as an example, in-person, one of the benefits of in-person is it can allow interactions in person and full physical assessment, and provide a private and neutral location. And an example of video conferencing and telephone benefits might be that it can reduce the need for travel. It can be more convenient for the person receiving care and family caregivers, and can improve access to care in the home community, can allow for the person receiving care to practice skills in the home environment, and facilitate the involvement of family caregivers and other support. So these just give you examples of some of the benefits. Next slide. And then looking at some of the potential limitations of the different modalities. So in terms of in-person, there can care can be limited if there's no experienced professionals in the area. It can be costly for the person receiving care. For example, the cost of travel, parking, time off, childcare can be less convenient and flexible. And if we go and look over at video conferencing and telephone, some of the limitations there can be privacy and confidentiality concerns. For example, if the person doesn't have access to a private setting, or if you look at video conferencing by itself, that requires consistent internet connectivity and access to technology and might perpetuate certain barriers or digital inequities. So this just gives you an idea of some of the considerations that we would want clinicians to be thinking about as they're choosing the modality of care. Next slide.
Great, thanks so much, Michelle. So in terms of evaluation and iteration of the guidance document, an evaluation reference group was established to provide input into the evaluation approach for the guidance. A third-party evaluation vendor was selected through a competitive process. We rely on partners with links to the target audience to assist us in the communication and evaluation activities. The findings from the evaluation are intended to instruct the further iteration of the guidance. And really, successful evaluation is dependent on being able to reach the target audience of the guidance, raise awareness of the existing guidance, recruit willing participants to complete surveys, participate in interviews, as well as focus groups. And next slide, please. So again, sharing where you can find the eating disorders guidance, the same pathway that David mentioned for the primary care guidance, but then there is a tile there for eating disorders. So we will wrap up with that, and thank you so much for your time.
Great, thank you so much, both Michelle and Tamara. It's my real pleasure next to introduce our next two speakers. Ruth Ann Lobb is currently a senior business lead with the Population Health and Value-Based Health System portfolio at Ontario Health. With a background deeply rooted in healthcare as a registered nursing professional, Ruth Ann brings a wealth of expertise and a robust set of qualifications and certifications to her role. She has certifications in business administration, long-term care administration, Canadian privacy information, change management, and lean. And these really underpin her ability to offer strategic leadership across various healthcare sectors. Ruth Ann's proficiency extends to providing advice on implementation, governance, clinical adoption, and change management within Ontario's healthcare innovation strategies. She feels privileged to have had the opportunity for the last several years to collaborate and work together with a cross-functional multidisciplinary team across various provincial digital healthcare projects that have been instrumental in shaping innovations across Ontario. Dana Saunders is currently the lead co-design and engagement for Health 811 and patient navigation in the same portfolio at Ontario Health. Over the last 10 years, Dana has been responsible for leading patient experience initiatives at various hospitals in Southwestern Ontario, leveraging a strong background in quality improvement, lean, and experience-based co-design to include the patient voice in system transformation at the local health system level. She is particularly passionate about health equity, supporting specific Indigenous engagement in various projects and in Health 811. Dana holds a Master's of Health Administration degree from the University of Regina and a Lean Green Belt from the EZ Sigma Group. Today, they'll be discussing the current Health 811 service and its vision and its approach to triaging those requesting health advice in Ontario and the use of digital tools to support people across Ontario to access care wherever and whenever they need it. Over to both of you.
Thank you, David, for that introduction. So to give you some understanding about the Health 811 program, I would like to go to the next slide and we'll just go over the background a little bit. So the Ministry of Health began the procurement process in the fall of 2019 for the Enhanced Navigation Service for Ontario. And the aim was to provide digitally enhanced services and to enhance that telehealth service by launching one website and one number to call, which was Health 811. And with this enhanced service, Ontarians will continue to be able to connect to a registered nurse by phone, now as well online chat. This service does not replace 911 for a medical emergency. 811 is specifically for non-urgent health information, advice, and referrals. Now, after a rigorous procurement process, the contract was awarded at the beginning of October 2021 to a consortium of vendors called Better Access Alliance, and that includes Orion Health, SE Health and PhoneMed, Ada Health, as well as Think Research. In late 2021, the MOH assigned the contract to Ontario Health, and we are now overseeing the implementation, including ongoing management and operations and performance of this service. Next slide, please. To give you some key highlights about the differences between Health 811 and the previous telehealth model, I want to let you know that the model of innovation is very much a key part of the Health 811 program and a unique approach to engagement and transformation of the service. The first piece is around governance. So patients and providers are key partners and are part of the governance of the service. And those partners sit at a Partners Advisory Council. They do help guide our annual roadmap planning. They also allow us to take a human-centered guide to our annual roadmap planning, which Dana will speak to you about a little bit later. They also allow us to take a human-centered approach to design as well. We do strive at Health 811 to co-design services and enhancements with patients, with caregivers and providers in the design process to ensure that the service is in fact meeting the needs of the end users. Another part of this model is quite unique. It's called a value-based incentive framework, which means that we're moving away from a volume-based contract to a performance-based contract tied to quintuple aim, and really aims to focus on the quality of services provided. So health outcomes and metrics are going to be tied to funding for the vendors so that we're ensuring that we are aiming to enhance population health and support an upstream approach to care. There is a robust clinical oversight with the alignment of Ontario Health Quality Guidelines, which guide the service development. We use industry standard Schmidt-Thompson protocols, and they are embedded into a triage decision support software, and that is assisting with the clinical triage. Finally, the contract flexibility enables a flexible roadmap planning process that supports the discovery as well as the enhancement of the service with Ontarians, and allows for the flexibility to respond to human behavior and new technology enhancements. Next slide, please. So our vision. Health 811 was launched in April 2022 as the evolution of the old Telehealth Ontario model, and it includes digital enhancements and supports patients throughout the healthcare journey. The intention is to have one place that can act as an entry point to the health system for all Ontarians. What we've been building and will be continuing to build will become the foundation for a consolidated experience across healthcare services and integrations for patients in Ontario. We do use the term digital front door to Ontario's healthcare system because we're offering a place where all Ontarians can access health information, advice, and initial triage support, and also to become connected to publicly funded healthcare services such as their Ontario Health Team, and related information and supports available across the province to guide them through the healthcare journey. Currently, we offer non-urgent healthcare information and advice to patients seeking care. We aim to make healthcare easier and more accessible to people who live in rural or remote communities. We also strive as part of our vision to improve communication and coordination of care among healthcare team members, and we also provide people the opportunity to navigate those services easily. Next slide, please. To give you some understanding about our core features of the service today, the first core feature listed there is the symptom assessment tool. So a user will go through several questions related to their symptoms, and the tool provides potential causes of the symptoms, as well as potential care options for them to pursue. So, for example, if your symptoms include A, B, and C, it will maybe guide you to seek care immediately, or also maybe guide you to seek care within the 48 hours and touch base with your care provider. The second core feature is the medical library, and it is an informative resource that offers users insight into common conditions, symptoms, treatments, and preventative measures. It provides versatile search options for ease of navigation. And so the users can directly type what they are looking for into the search feature and browse through a list of commonly searched terms or navigate an extensive alphabetical list of medical terms. It also serves as a comprehensive, user-friendly medical encyclopedia, helping users to understand their health better and make informed decisions about where they seek help. The third core feature is the telephone service, and this is the classic telehealth service where patients are connected to a nurse 24/7, 365 days a year. It is a health service directory as well, where patients can locate specific services. And then also we have a chat feature, which connects patients to a registered nurse or to a system navigator. So if they have a question about something, they can pull up the chat and speak directly to one of those individuals. Right, next slide, please. Thank you. So to give you a high-level understanding of our programs, Health 811 adopted a number of legacy programs from telehealth, and that includes nutritional information and counseling, breastfeeding support for new moms. We have a refugee health line. We also have coordination service for MAID. We have smoking cessation supports. And these are all the programs that are included in the Health 811 platform. We also provide support for registration to the Healthcare Connect program, which aims to connect patients with primary care providers. All of these services are accessible by phone, by website, on a desktop or laptop, as well through mobile devices. All right, I'm going to hand it over to my colleague Dana Saunders, and she will continue with the presentation. Next slide. Thank you.
Thanks so much, Ruth Ann. So another unique feature of Health 811 is the work that is currently underway to better support Indigenous patients who use the service. So through our partnership with our vendor, we've determined that the service has historically not been widely used by Indigenous people. And we know that in order to make it culturally safe and effective for First Nations, Inuit, Métis, and urban Indigenous people, we need to support relationship building with each sovereign First Nation, with the First Nation health teams and tribal councils across the province, to really better understand the needs of Indigenous patients and consider digital solutions that will meet these needs. So for this reason, Health 811 has specific goals built into Ontario Health's annual business plan with outcome and process measures planned for the next 3 years. We're aiming to specifically link digital enhancements in our upcoming roadmap to the needs identified through our Indigenous engagement. And the focus of this year has been to continue to build relationships with Indigenous partners to better understand some of the patient journeys and to identify gaps, and also to understand how to make the service more impactful for Indigenous patients. We know that access is an issue, and we want to continue to enhance the service as it stands today for the Indigenous people who use it. Next slide, please. Thank you so much. So user stories are an important way for us and our team to illustrate the impact of Health 811 and show you both the functionality that is currently available with the service, but also to illustrate some of the plans for integration and enhancement over the next couple of years. So this is Dave. Dave is a diabetic who has a sore on his foot, and the sore is getting worse. He's a type 2 diabetic, and he doesn't have access to primary care since his family physician retired about 6 months ago. So Dave, looking for services, calls 811. He is registered by the nurse, who decides she needs a bit more information. So she sends Dave a video visit link, so that the wound can be assessed better. The nurse assesses David's foot through the video visit and provides some advice on how to care for the wound. And then the evolution of this service and the enhancements that are coming in the next couple of years would be that the nurse would be able to also warm transfer Dave to services locally within his OHT, so he can connect with things like diabetes education locally and also access other local supports that will support his diabetes. Next slide, please. So this is a high-level version of the planned roadmap for the 2024-2025 fiscal year. We like to issue the caveat that the order of some of these enhancements and some of the enhancements overall are subject to change. But we want to share that there are a great number of exciting enhancements and products upcoming for Health 811. So there are a number of change ideas that have been identified through our spring ideation sessions. Ruth Ann mentioned that that's part of our annual roadmap process where we meet with partners to explore potential new ideas. So back in April, our Health 811 team met with over 300 partners through 21 ideation sessions. We heard great feedback about the service. We then reconvened with a few of these key partners in the summer to make a short list and do some co-design on these enhancements. So in addition to those change ideas that have been selected, I just wanted to highlight a few other features. We know that the Provincial Health Services Directory data feed, which is one single source of truth for all Ontario, for all health services in Ontario, will be integrated into Health 811 on our service directory next year. There's also very exciting work currently underway at Ontario Health with respect to patient access that will allow patients to securely access health information throughout the continuum of care, and the Provincial Patient Viewer, which will allow patients to view their health record being completed next year. So lots of great enhancements coming in the next year intended to support the patient experience and enhance the patient's use of Health 811. And I think that is it for me. Next slide, please.
Great.
Thanks so much.
Thank you so much. So I want to thank Ruth Ann and Dana. I want to remind everybody that they can enter their questions in the Q&A box and we will get to them. So I'm wondering, we'll have a look here at the questions and answers. There was a question from an attendee about somebody who has elderly parents and has had the opportunity to work from home during a virtual care visit with a specialist. Is there an opportunity to use the same format so they can learn how to use that format for any virtual care provided? I'm going to assume this question is about using the same virtual care platform. So currently in Ontario, there are a number of video platforms. It is up to the individual either health service organization or doctor's office around what platform they use. Often that's because certain platforms interact directly with their electronic medical record system. And so we don't have one electronic medical record system in the province, both in the community and in our hospitals. We do, though, for a variety of reasons, have a verification standard for video visits. And what that means is that the same functionality should be available for each of those products. So for instance, the ability to actually do a three-way video call is something that the products need to have. So that means that caregivers don't need to necessarily be in the same physical location as the people they're caring after. So if somebody happens to need to be at work and mom and dad are at home, you can have a three-way conversation with the healthcare provider. Another example would be screen sharing so that you can, as we heard, like look at logs, share test results, that sort of thing in real time with patients. As I'm going through these, maybe I'll ask the panelists to address a question that I know I hear a lot when it comes to virtual care. And it relates to both Health 811 and the provision of of virtual care. And that is, how do you foresee the best way for either somebody answering the phone in a family physician's office or the nurse on Health 811, sort of trying to figure out with the patient, if there's a variety of different modalities, either telephone or video, what's the best modality for that patient, and whether or not that patient actually, in fact, needs an in-person assessment. I think, navigating that sort of multi-channel access that we are establishing in the province to providers has become a lot more difficult for the medical office assistants and nurses who traditionally had one mode of access, which was just the telephone. I wonder if any of the panelists want to address that. Don't all jump out at once. Maybe while you're thinking at it, there's an easy question that I'm going to address. There's a question about, are care providers compensated equally for virtual and in-person visits? So I'm not an expert on billing in Ontario, but I can say for physicians, the video visit is compensated the same as the in-person visit. A telephone visit, I believe, is discounted at 85% of the compensation for an in-person or video visit. So there's a bit of a discount if it's a telephone visit on what the provider is able to bill OHIP. There is a question here, I think that Ruth Ann, maybe you want to speak to it directly about the advertising for 811, what the plans are to increase public knowledge about the service. You're on mute.
I can speak to this.
Oh, yeah.
Actually.
Oh, there.
Thank you for the question. A great question. As part of our ideation work that we did back in the spring, this was one of the themes that we heard a lot, that not as many people are aware as 811 as could be. And, you know, the opportunity to have access to this as a service is really huge for patients. So we know that this is something that people are asking for. There was actually a fairly large campaign back in the winter months. We had a multimedia campaign with there was a few big high level spots on the Super Bowl commercials and also with the Oscars. So there has been a lot of promotion, print and also radio promotion as well. And I know that the Ministry of Health is gearing up to do more promotion of the service as we go forward.
Great, thank you so much. There was a question here again about Health 811. Given all the HHR challenges from hospitals, partners, the community, does OH foresee any barriers to recruiting nurses and others to support the volume of incoming calls? And is there been an assessment or an ongoing evaluation of wait times for the Health 811 service?
Certainly, I can speak to this. So absolutely, I mean, we continue in the province of Ontario to struggle with ensuring that we have adequate resources for registered nursing supports. Currently, we are managing very well with the wait times. Our vendor, our Health 811 vendor, SE Health, has done a great job ensuring that we have adequate number of registered nurses to answer the calls. Currently, our calls are being answered within 60 seconds to speak with a system navigator initially, and then to be forwarded on to a registered nurse as the symptoms dictate. So absolutely, we're looking at that. Call back times, we're absolutely continuing to look at that and evaluate the callback times certainly every month and as needed. So I know our Better Access Alliance vendor is doing a fantastic job to make sure that we are keeping those callback times as tight and as short as possible.
Hey, everyone. I think it might be, or David has just dropped off. There are still a few more questions in the box. Any questions that we don't get to, the team will summarize them and do our best to get the answers and then share them back to everyone. And there are a couple questions about the sharing of the slides. We will, once they're finalized, we will have them posted in our quorum, and following the session, we will share the link to the quorum where people can access the slides and any other tools and resources that we've talked about. So I'll look to the team. I think there are a couple of other slides before we close the session. Thank you to all our speakers. Oh, I think we're having. Great. Okay, so that takes us to the end. And I see there are still a couple of questions, but we will summarize them and we will share the answers to those with everyone who's participated. We would like, before we close, to ask a couple of standard questions just to get your feedback. We are continuously looking for opportunities to improve and want to hear from each of you. So you should see a couple of questions. We would ask you to take a moment before you log off to answer. So the first one is up. How would you rate the quality of the session? Just give it a moment.
I'm going to have to apologize to everybody. It seems like my power went out. I've had to reconnect from my phone.
No worries. Thank you, David. We
Okay.
did note that we will go through the questions, and any unanswered questions we will do our best to answer and share back with registrants. So we're just doing our post session questions. I think we're on question 2 now. How likely are you to apply at least one idea from the session in your practice? And then the final question, oh, they're already answered. How would you rate the topics covered in the session in terms of relevance to your work? Excellent. Thank you all for taking the time to join us. A huge thank you to our speakers who took the time to share with us today. And for all of you for joining us. And we hope that you'll continue to participate with us. We will share a link to our community space on Quorum, where we have lots of information, tools, resources, links, and we will have the slides posted there as well. So thank you, everyone. And we hope everyone has a great day. Thank you so much.
Bye-bye, everyone.